get, doctor?
So, associated with enlarged adenoids, which is like tonsils behind the nose, is a big lump of lymphoid tissue that sits behind the nose. It's very close to the opening of the eustachian tube, and this can either cause obstruction or inflammation of the tube, and this gives rise to fluid building up in the middle layer. When the fluid is sterile, we refer to this as gluear or otitis media with effusion. This is distinctly different from acute otitis media, which is what you get when you get a cold and the child is very irritable with fever and complaining of pain. In terms of gluear, the child loses hearing of about 30%, and this is not usually recognized easily. Sometimes the teacher may notice it in the classroom that the child is not hearing, or sometimes the parent may find out that they have to repeat instruction to the child repeatedly. But 30% hearing loss is not deafness, it's just reduced hearing, and also reduced perception of some of the consonants such as CH, SH, and Fs. For example, the child may not be hearing this, and therefore the pronunciation of words will become affected. So if you ask the child to say school, they will not say school, they will say ool, because they're not hearing the SH. And this is a problem in terms of mental development, especially in this competitive world. We cannot afford to have this condition go on for too long because we can treat it. We normally wait a period of 3 months, which is the international guidelines, before we do something. During this period, we try medicine. If it works and the child improves naturally, all well and good. If it doesn't, then we have to intervene with something called grommets. At the same time, we take the adenoids out because that's the root cause of the problem. And this has been confirmed by a randomized control trial done in England, which is called the Target trial. If you take the adenoids out and do grommets at the same time, the child improves for a longer period, and also the respiratory health of the child improves tremendously. They also appreciate food much better because they can smell the food and taste it better after you take the adenoids out.
So how do you take the adenoids and tonsils out?
So the latest technology regarding adenotonsillectomy involves ablation. Over the years, there have been many methods used to remove the tonsils and adenoids. And the reason for this is that there is some pain associated with all methods. But the latest technology, which is ablation, reduces the pain significantly and also reduces the bleeding. This is very advanced technology. It's actually better than laser. A lot of people think that laser is the bee's knees, but it's not. Ablation is much better. It's dissection at a colder temperature. It's well controlled. It's done under direct vision. The only setback is that the equipment is a little bit expensive procedure, and we offer single-use ablator to every patient, and the results is fantastic. Parents will tell you that they're very happy. They take the child home the same day. If you do adenoids and grommet, the child can go back to school the next day. With tonsillectomy, only a few days is needed. And we've also modified our technique for tonsillectomy. We now perform tonsillotomy, which is extremely safe and beneficial and produces very, very little pain and no bleeding whatsoever.
If you have any question, we will ask.
Thank you very much.
So one of the patient is asking, what causes tonsils? What causes of tonsils?
So tonsillar hypertrophy is maybe due to recurrent infection, but one of the commonest cause for the tonsils getting bigger is tonsil stones, which consist of special bacteria called actinomyces bacteria, and this also causes bad breath. Dead tissue, dead particles of virus, food, and epithelial cells tissue. These form little balls that live in the tonsil and produce a chronic low-grade infection. And the reason why this happens is that the tonsil, it has creps inside, and these are little holes in the tonsil where things accumulate. And over time, this inflammation results in tonsil hypertrophy. Some children may also have naturally big tonsil, which may run in the family due to genetics. But the main cause for asymmetrical tonsil or tonsil hypertrophy is due to chronic low-grade infection caused by tonsil stones or tonsil lath. And if you Google it, you'll see these white particles in the tonsil, which smells very bad. They come out, there is no other treatment for it other than tonsillectomy. We can try and gargle, we can try and use mouthwash. We sometimes take them out in the clinic, but they always come back. So the cure is to remove the tonsil.
Okay, the other patient is asking, should I remove my tonsils if it is pain?
Well, it depends. We don't remove tonsil lightly. There are certain indications, for example, recurrent tonsillitis, sleep disorder breathing. If we suspect that it may be cancerous, if we suspect that there is halitosis associated with it, bad breath, or if we get in recurrent infection that's causing problems with our heart or kidneys. In terms of chronic pain, we need to see you, we need to examine you and find out whether there is another cause. For example, pain in the tonsil region may be due to something called a long styloid process, which is just behind the tonsil and causing a sharp pricking pain. And we have to do an X-ray or a CT scan to see whether your styloid process, which is a bit of bone that enlarges with time, or ligament that calcifies. We call this Eagle syndrome. So we need to make a diagnosis and then decide what is the best management for you.
How to know if I have adenoids?
It's very simple. You tend to get nasal blockage, which is chronic, and we can show your adenoids very quickly in the clinic if we put a nasal endoscope in your nose and we get a direct vision. The other way of diagnosing it is to do a soft tissue lateral neck X-ray, and it shows how the adenoids is compromising the nasopharyngeal area.
Is a sleep disorder breathing as the same as sleep apnea?
No, sleep disorder breathing is a very big term, of which sleep apnea is one of the components that's present under this umbrella. As I mentioned, it consists of 4 diagnoses: sleep disorder breathing, which is snoring, and I don't mean mild snoring, because all children snore at some stage of their life, especially if they have a cold. I mean severe, moderate to severe snoring. There's another diagnosis which we call respiratory hyperventilation, where some physiological parameter changes, such as your pulse pressure, your blood pressure, your pulse rate, and so on. And then there's upper airway resistance syndrome, which is different also from obstructive sleep apnea. They're physiologically a little bit different, but from a lay person point of view, just think in terms of snoring and obstructive sleep apnea. And the umbrella term for all of this is sleep disorder breathing, but it consists of 4 diagnoses.
Should I meet a doctor if my child is having snoring and a hyperactive?
Absolutely. The problem is, if your child is snoring severely or there's any obstruction of the airway, what happens is that at night, the child is using all the energy to pump the little oxygen around the body, so the heart is working really hard, and that's why the child sweats and is always restless. This means that the energy that the child should be using to grow goes towards circulating oxygen. So the child is normally quite thin, they're not growing, and this is because the sleep is not good. Energy is used to circulate the oxygen at a rapid rate, because there's not enough oxygen when you have sleep apnea or obstruction. The energy at night should be used for growing. That's why when we do the operation, we'll see an exponential increase in the child growth and development, as well as an increase in weight, because they're able to smell and taste food better.
Okay, thank you, doctor, for joining us.
Thank you very much.